Hello, everyone. I'm excited to have this great set of guests for our webinar today on newborn screening and some of its implications for the future of pediatric healthcare. I have three amazing guests with us today, Dr. Wendy Chung, Dr. Peay, and Kira Dineen. We're going to cover some of the most incredible new studies that are looking at large-scale newborn screening and also get the perspective from Kira, both as a podcast host that hears from all kinds of cutting edge genetics programs, but also as a practicing genetic counselor in prenatal genetics. So I hope you enjoy this day. And we're just going to start off here by asking each of the guests to give a quick overview of their background and also why they became interested in newborn screening in particular. So Wendy, you're first on my screen. If we could start with you, that would be great.
Sure. I'm Wendy Chung. I'm the chair of pediatrics at Boston Children's Hospital. I'm a medical and molecular geneticist, and my interest in newborn screening dates all the way back, actually over 30 years ago when I started studying phenylketonuria at the National Institutes of Health. And with that, grew up professionally with the Genome Project and had always envisioned a way that we could be able to get to beyond just PKU. And so I've been operationalizing that, trying to think about how we can leave no child behind as we do that through a public health program.
Amazing. Thank you. Holly, would you like to go next?
Sure. I'm Peay. I'm a senior research scientist at RTI International. I actually started my career as a genetic counselor, and I was particularly interested in adult genetics and bioethics, and have moved more toward the large-scale research as I grew my profession toward a focus on complex decision-making and ethical application of new technologies into research and clinical settings. So that is what moved me toward looking at application of genome sequencing and other genetic technologies in the newborn period.
Amazing. Kira?
Yeah, so my name is Kira Dineen. I am a prenatal genetic counselor. So I see patients a few days a week in the United States. And I also produce and host some other podcasts, mostly in the genetic space. So my flagship show is called DNA Today. And Dr. Short, as you were kind of mentioning, I've had a few guests on that we've talked about, this concept of, can we get and how do we get to newborn genome sequencing and have that be a standard of care. So I think I've just been very intrigued by this and, love talking about it and doing episodes about it. We had an episode with Dr. Stephen Kingsmore, who's, I think big in the space along with our guests here today. And it's just really interesting to hear from Rady Children's, how that's going, and also the perspective between the different countries too, of just, how that's going in the different projects. So I'm very honored to be included with, Dr. Chung and Dr. Peay, because you guys are really leaders in this space.
Yeah, agreed. It's going to be a good discussion. Maybe, Wendy, if we could start with you to give a little bit of an overview of the Guardian program that you're a PI of. What are the main focus points? What makes it different from some of the other studies that have been run in newborn screening in the past? And what kinds of questions are you trying to answer?
Sure. So Guardian stands for genomic screening of all newborns, or genomic uniform screening for all newborns for rare diseases. And the start with this actually was back in 2016 when we started a pilot study for newborn screening with the New York State Department of Health for spinal muscular atrophy. And it was really through the success of that program and building the infrastructure through that program, and importantly, starting to engage the parents who are part of that study in understanding what would they want beyond SMA. Short story SMA, I think, was very successful and is now on the recommended universal screening panel. But parents really taught us over a period of 4 to 5 years about how to think through this with going beyond SMA. And that really helped inform what we wanted to do, which was exactly design the study that parents wanted, which was use a newborn screening blood spot, use the infrastructure of newborn screening because it already exists and it's very easy to add on to that. But go to additional news you can use, additional conditions that are early onset, highly penetrant, with hopefully very high, but not, it doesn't have to be 100% specificity in terms of doing this, but with high certainty that the child would be affected with something that we could do about it. And we've really built out Guardian based on those guiding principles. And with the ability to iterate and improve over time. And so the reason we went with genome sequencing as the backbone for doing this was because it gave us this infinite flexibility, both to take conditions and add them on or take them off as treatments became available and as we had new technical ways of analyzing the data. So we've really, built the program around doing it and doing it at scale in a location that is New York City, that's incredibly diverse in every dimension I can think about to think about how to generalize this. And so, as I often say, if you can do it in New York, you can do it anywhere, because it provides some of the opportunities and challenges that globally around the world we're facing. So in a nutshell, that's what it is. But I want to emphasize, although the program Guardian does the screening again with genome sequencing and looking though at only a subset of the genes. So even though the whole genome is there, we only analyze and look at the subset of genes with that news you can use. I also consider it to be important to go not just from screening, but confirmation to the diagnosis and onboarding those children to care. I consider all of that within scope of Guardian.
I'd say it's a pretty wide scope, and I think we're going to come back to some of the opportunities and challenges that you mentioned there. But before that, Holly, it would be great to just have an overview of the RTI program, and also if you could contrast any areas where you're doing things differently than Guardian, just to help people understand these programs get influenced and pushed in different ways. So it'd be really helpful to hear some of the different decisions you've made about the structure.
Of course. Yeah. I think one of the things, again, I think I already alluded a bit to this, but I think one of the things that is interesting and quite remarkable are actually the number of similarities between the programs, given that they grew up in parallel at a similar time. We also started Early Check. The funding for Early Check started in 2016, and our screening started in 2018. And we initially, similar to Guardian, screened for a very targeted particular number of conditions. So we started with SMA, Duchenne muscular dystrophy using CK-MM biochemical screening, and Fragile X. And so we conducted that screening from 2018 through 2023 with those conditions sort of coming off and on as we, SMA is a lovely example of a condition that went from pilot studies directly into our state newborn screening study. And I think Guardian, probably similar to Early Check, was able to really inform the transition of a program from a research pilot to public health screening. Early Check is a study that's conducted across the state of North Carolina. So I think that is a difference, that we have a statewide program. Our study is conducted in collaboration with our state laboratory of newborn screening. And it's a really critical collaboration, both practically because it allows us to recruit from the entire state and to use residual dried blood spots that we have access to after state newborn screening is complete, but also because the close collaboration and having the director of the state laboratory as one of our PIs on our program really roots our study in thinking through how do you efficiently and appropriately take something from a research setting and move it into a public health setting. So I think that's a critical component of our study. And I think, again, similar to Guardian, we started looking really, almost when we started screening in 2018, started thinking about how are we going to meet future needs. And the future needs were really driven both by genetic and genomic technology, but also by the really incredible pipeline of therapies that are being developed for rare conditions, and particularly therapies that are going to have the most impact when they're done very early in a child's life, even pre-symptomatically. And those two sets of technologies coming together really made us think that we needed to transition from a condition by condition sort of pilot program to one that uses genome sequencing as the backbone. And the flexibility that Wendy talked about is incredibly important. The other thing I think that's a bit different about our project is we're also offering parents genetic risk score for type 1 diabetes. And so having that data is generated when we do the sequencing for our rare condition panels. And so being able to offer something that moves us more toward a precision public health approach is just testing important new boundaries for where public health may go in the future. I think the one other thing I'll say is similar to Guardian, it is really important that we do a couple of things for families. One, that we understand what they want and what they need as we move through programs like this, because that data is critically important for later transition and for doing studies well. But also that we don't leave families in a situation where we've provided a set of data that often are uncertain about what the future of their child's health might look like, without being able to do some confirmatory testing, second rounds of testing, and definitely a nice warm handoff into future care. So those things are critically important, that we develop models and test models like that would allow future public health implementation.
Yeah, super. Kira, I'm interested in your perspective on this. As I mentioned at the top of the show, you have two perspectives. You host a very popular podcast, and you've heard from a lot of leaders in this space, but also you work directly with families on prenatal genetic testing, and you get to hear firsthand some of the questions, concerns, ideas that they might have for how this could help in the future. What have you learned as you've been a practicing genetic counselor about both the challenges, but also opportunities about not just newborn screening, but expanded access to screening around, both prenatal and postnatal journeys that families go on?
Yeah, I think it's always good to have that patient perspective in there. And when looking at the prenatal care and then transitioning into like that newborn phase, I think a big part is looking at carrier screening. So, for patients that are doing carrier screening and they're doing, I don't know if we're still using the term expanded carrier screening or looking at hundreds of conditions as opposed to say, 20 or less. So when it comes to that, when I have patients that, come back as carriers, the same condition as the sperm donor or the father of the pregnancy or whatever term we're using for that, often part of our conversation is, okay, are we testing during pregnancy? Is that something that you want to do? Because in most cases, that involves an invasive test called amniocentesis or CBS, and there's a risk for having a miscarriage with that. So some people may be adverse to doing that, which completely makes sense. And depending on the conditions, severity of condition, the couple or that person, their families, decision making around that. Obviously, there's a lot that goes into it, but something that is helpful is when I know that condition is on newborn screening. I think Dr. Chung brought up a great example of PKU, right? That's how newborn screening started, as far as I'm aware. I wasn't around at that time, but that we started with PKU. And if I have a person and the other biological parent are both carriers of PKU, I know I can say to them, no matter what state they're having this baby in the United States, which for me, it would pretty much be New York or Connecticut, but that baby is going to be screened for PKU at birth. So that's not something that they're going to have to go out of their way to do. It's just going to be part of the standard care. So that's something that's helpful when it is a condition that I know is either on the Connecticut or New York list, because every state's going to be a little bit different in the United States. But there's some conditions that are just every state. But then you have that discrepancy of care. Like, well, what if they're a carrier for a condition where in the state that they're having this baby, that's not included in the screening? Okay, great that they know about it ahead of time because we did carrier screening or I'm talking to them about the carrier screening they did elsewhere. But what about for those conditions that didn't come up on carrier screening? What about situations where we can't test the biological father or people never get offered carrier screening, which unfortunately happens? So I think it's something that would increase, not necessarily, I guess, like, access to care in terms of having that be standard of not missing certain, cases, and especially for those conditions where early treatment is really, really important, which is one of the criteria to have something included in the newborn screening as we have it today. But with being able to, update to genome, we're going to be able to catch a lot more conditions, and then people can know about that so that early treatment is going to be, really instrumental in changing that baby's development. So I think that's one area I think about in terms of how, patients in my conversations with them, where newborn screening comes up and what they're asking about. And even on the flip side of conditions that are maybe on the more mild end, I think, something like biotinidase deficiency, where we have a really good treatment for that, where untreated, I would not describe that as a mild condition, but that's something that people may not decide to test for during pregnancy and say, you know what, we'll learn if this baby has the condition and then we'll get them on the treatment. So sometimes it's just nice knowing that it's part of their care. And I'm sure we'll get into like, okay, well, how accessible is this going to be, the cost of it and all that. But that's kind of what I think about too, in terms of what I've had discussions on my podcast, that, okay, this is a great technology and the cost of sequencing has dropped so much, right? The Human Genome Project ended, about 21 years ago. So we've really made a lot of advancements in that time. But at the same time, how are we going to get to the point where we can fiscally do this for every baby? So that's something I'm sure we'll get into, but that's something that I'm always
Yeah,
thinking about.
let's go there right now. I think it's a great topic. Wendy, Holly, how do you think about how we get this from a couple thousand people per month or a year at the scale that I think you're at to universally accessible, at least in the jurisdictions that you're thinking about? Maybe we can parameterize it as nationally in the US, because I think you both have an opportunity to kind of push that national screening envelope. How do you think about that?
Well, I think personally, these studies are trying to gather the evidence and the data to understand what is that cost going to be and to iteratively refine it to figure out how we can bring down the cost. I'll certainly speak for Guardian, which is that we did pick genomes quite intentionally. This is short read genomes for those of you who are real aficionados. And we did that to try and give us the most latitude for understanding what we could see from that versus, for instance, exomes or more targeted even panels that would go forward. I agree with Holly that this is still a very dynamic space, that I'm still convinced that you need something that's a genomic test to give you the infinite flexibility to go forward. And especially when you think about revalidating tests and what that costs us in terms of doing this, and especially if the FDA comes in with something, I do think kind of doing this once for the validation is going to be the way to go. I will say right now there's a big cost differential between exomes and genomes, and I'm waiting to see what happens with that over time. I'm not weighing in until we see what those costs ultimately come down to. But if they were at 2024 numbers, I'm not, I do think it's big differential in terms of cost, and the sequencing cost itself is a very big, in fact, the predominant cost of what these pilots at least are costing me to do. And so in thinking about operationalizing that nationally, I do think we're going to have to bring the cost down significantly from what it is now. On the other hand, I do think that like I said, we are trying to keep our options open and know, I'll just throw it out, even different technologies. Is it short read or is it long read? How much benefit do you get from that? I don't think we know. I think that dark matter of what we haven't seen is just now being tapped in terms of understanding what you can get from understanding chemical modifications, DNA methylation, repeats that we might not be detecting. So I'm just going to put it out there. I haven't personally figured out what this is, but I do think it's going to be, as we have more knowledge and as the prices come down and as some of the new technologies for different methods of sequencing become available, I think what we're trying to do is at least build the evidence base beyond the tech side of what the clinical sort of operations and implementation are, because I don't think that's going to change regardless of what technology or platform we use for the sequencing.
Yeah, that makes sense. Holly, what do you think?
Yeah, I think that's exactly right. I mean, no public health laboratory would implement a study like we're doing. Our public health application of a study like we're doing. I mean, we're doing research because there are empirical questions that need to be answered. And cost is an important one. And it's not just cost for the technology to do the screening, it's cost for the follow-up. So, again, we're going to have a situation where we're going to have a bunch of children going into the healthcare system who need subsequent testing and care. And one of the challenges I'm sure we're going to get to is that there is incredible phenotypic variability when you do population screening that you do not see in clinically ascertained populations. And we really need to understand that much better before we think about putting this in public health, because we won't have a good feel for what those downstream costs will be, or even who is actually going to need access to these, in most cases, incredibly expensive targeted therapies that these children can benefit from, until we have a better understanding of what phenotypes actually look like when we are in a population, unselected population, especially populations like in North Carolina and in New York that are diverse, that are ethnically and ancestrally diverse. So I think there are many, many questions before we can start to really understand the economic implications of these studies. And one thing I want to just step back to is there are also really fundamental questions that studies like ours are answering about whether people even want this kind of information, when they want it, how they want it. And so economics are a part of that equation, but I think the more fundamental part of the equation is how we do this well. And we don't know that yet. And so those are critical questions that maybe we can talk about a bit more as this podcast goes on too.
Yeah, I was really interested in the framing that you used, Wendy, of news you can use. I really like that. One of the things that strikes me about that, though, is that it is going to vary a lot depending on the person. Some people will say, I can use everything, bring it on. And other people will say, I can use an actionable thing that I can really do something about. How do you all think about how the aperture expands or stays focused on this over time? And to what extent should participants drive the decision around what I want to get back from a program like this versus needing to draw some practical lines in the sand and say, look, we want to provide a link all the way to clinical care. And so at the stage that we are, there's only so much that we can do and make sure that everyone that comes through this complex process gets the right experience. How do you think about defining what the news they can use? I really like that phrasing. I'm going to keep using it, I think.
So I'll actually credit Holly for this and say that we build upon each other. So when they had started Early Check, one of the things, as Holly said, they had included was Fragile X, and I know that when groups have thought about this, that was one of the questions: is how actionable is Fragile X, given that we don't have a therapy that modifies the condition. And so we actually posed that to our families and asked them specifically about that use case, but other neurodevelopmental conditions and how actionable that was for them. And we settled on something that ends up being neurogenetic conditions that are highly penetrant, early onset, and associated with epilepsy. And the association with epilepsy, at least in a portion of the individuals, was that's what families felt like that was something very concrete and treatable with a high enough probability of something that medications could treat, even if you couldn't cure, with a capital C, the underlying condition. And so that was the compromise that we came to, knowing that we needed to learn from that as a first use case to be able to ease into that group of conditions. And I'll say, I'll just be honest, that's not something that many other newborn screening programs, have said was, within the actionable group. And so it's an experiment that we're doing. I think the interesting thing about all of us doing slightly different studies is that we're all learning from each other because we're not cookie cutter doing the same thing. And like I said, I do think we're building on each other to do that. I will say, and now that we've had some data back, and just to give you an example, in Guardian, we've now gone through returning results to 8,000 babies in New York City. And so we do have a sense of what the rates are like. Is that used? Do parents still feel that information was usable? How are they feeling about getting back that information? I will say that across the board, our decision regret scores are low. And this is with about approximately 75% of individuals wanting to do the study. But we have identified, a couple use cases where we can do better, and we learn from that. And we actually, very much, I would say, get feedback and say, give it to us straight, give us all the details in terms of what we did well, what we didn't do as well as we could do in the future, so that we can continue to iterate and improve. And so we value that partnership that we get with the families. And I do think literally at least once a week, we make slight adjustments to things to continue to improve based on the feedback we're hearing.
Yeah, that's great. Holly, I know you've done something that I think is pretty unique around including the type 1 diabetes polygenic score as I think the tier 3 option in your program. Maybe you can talk a little bit about that and any examples that you have of using the participant feedback or other principles to think about how you make this set of decisions.
Yeah. So we are using an implementation science framework approach that is very focused on developing and analyzing and refining a program as we go. So I agree that it is critical that we give ourselves space to learn from our participants and our communities, people who say no as well to participating, and having space to make changes. And we started screening in September, and so we're actually just starting some of these phases of assessment back with families to get their feedback. So I don't have a lot of data to provide to you yet. That'll be several months coming, but we already, of course, are from returning results to families. We're already hearing feedback about the kinds of things that families are finding concerning, and it's largely around uncertainty. And so, we're returning results that are much more uncertain than the results that we returned in the first phase of early check. Even things like CKMM testing had a very high false positive rate. At least we went to families and we said, we know that there's a very high false positive rate and we want to do a second CK so we can get a better feeling. And here it's, we're generating more and more data, but we're putting a lot of uncertainty in front of many families. The type 1 diabetes, I think, is an example where we really kind of flipping the tenets of newborn screening on their head, where we're not focused on sensitivity and specificity. We know that the majority of people we identify with a higher risk score are not going to have type 1 diabetes. That's the way these genetic risk scores work. So we approach them quite differently in our consent and our educational materials to really try to get families to differentiate between the rare monogenic conditions and between this type 1 diabetes. And the extent to which we've done it well will be part of our evaluation, but to prepare us to at least do as well as possible, we did extensive rounds of community engagement and formative research. And that formative research was with people in the community in North Carolina who are new parents or expecting parents, but also with people who provide care in our state and our newborn screening professionals, so that we can get an understanding of multiple different impacted parties about, how they're anticipating being able to potentially do this well in the future. So the data that you're looking for on how people are receiving these results is data that we're still collecting. And I hope that in the next, 6 months, we'll start to be able to report back on those kinds of outcomes.
Yeah, great. That's wonderful. I'll keep my eyes peeled for it. Kira, I was curious on your perspective on some of the themes raised about uncertainty and chance and communicating some of these complex concepts. One of the central challenges, it seems to me, about scaling newborn screening programs is just the sheer variety of use cases that we need to think about. It's, in many ways, it's kind of the ultimate challenge of genomics, of you're looking at every possible outcome that could happen, and you're only reporting and returning on a subset of them for now. And over time, I think that's likely to stay that way. But I imagine the job of a genetic counselor only gets harder in that situation. If you're thinking about pre-test counseling around what may come out of this test is a universe of possible things, and then also being able to have discussions on everything from carrier screening to actionable to non-actionable, different types of risks. How do you think about the job evolving, or maybe the nature of that bottleneck that I think we're going to have around skilled genetic counselors that really are critical, I think, for navigating this kind of pre and post-test counseling experience?
Yeah, Dr. Short, you bring up a great point and something I've been kind of thinking about, hearing what goes into this, or what data are we sharing? Is that data that parents want to know? We're now learning data for an individual that isn't at an age where they can assess if they want to do this testing, right, or consent to it. So I think that's another kind of issue within this, that if we're learning about conditions that affect in that childhood age, then yes, I think that's very much appropriate from my perspective. But also, who is giving all this information? Because right now with both of you, you have teams, I imagine, right? And so you have people that are helping with this. But if we're looking at it, at least just in the United States, there's about 5,000 genetic counselors. I think that includes Canada, but many genetic counselors within that are located in the United States. But they work in a variety of different settings, right? Not everybody is doing what I'm doing in terms of the prenatal or even the pediatric. I mean, you have cancer, cardiology, ophthalmology. I mean, so many different areas. And I think an interesting point is that as the genetic counseling field started a little over 50 years ago now, that we started really just in one space, and then we kind of branched out into all these different specialties. And in our graduate school, and our training is 2 years after undergrad or graduate level degree, in those 2 years, we still are learning about all these different specialties. And then many people are kind of like, all right, I'm going to start with this, or maybe I'm starting with two, doing like prenatal and cancer, something like that. But we all kind of end up specializing to some degree. But now I'm like, are we going to start seeing the reverse? And Holly, I'm sure you have points too, as being someone that's trained in genetic counseling, that are we going to kind of go back to our roots where genetic counselors are really supposed to be trained in all these areas, because we're going to need a lot more genetic counselors or people that are doing genetic counseling. So that can include other healthcare providers that aren't necessarily having the title of a genetic counselor. I think of nurse practitioners and people along those lines, but we're going to need a lot of people to be counseling and translating this information to people. I worry about how is that going to look on the pre-test side to get pre-test counseling consent there, like informed consent, versus the post-test counseling. Are we not doing pre-test counseling? Once we're looking at it from a population standpoint, I'm like, realistically, how is that whole part going to work? Because with newborn screening, the way we have it now, as far as I'm aware, it's an opt-out process. So everybody's going to be doing it unless you go through what I've heard is a lengthy process to opt out. And I've never personally heard of someone doing that. But we're looking at conditions that are actionable, right? As Dr. Chung was kind of talking about, how do we define that? That's a whole, conversation we had a little bit ago. But, for this, could we learn things that maybe the parents don't want to know? And do we give them the opportunity to say, no, thank you? So I think that's the part where I'm like, how are we actually going to put this into place? And I think other countries, along with these studies that we've been talking about, New York, North Carolina, but can we look at how other countries are doing it with a different healthcare system too? Because there's not enough genetic professionals or people that are trained in this to be able to even deal with the post-test counseling, let alone the pre-test informed consent. So that's something that I worry about a little bit.
Yeah.
And just our genetic counselors, even if there was enough of us, do we really know? Like, can I start counseling on a condition when I'm in the prenatal area? I don't know if I can start counseling on something that, is adult onset that comes up or something, and to prep and prepare for that session, that can take a long time to learn about that condition, make sure you can answer the questions for those parents. So I see a lot of logistical obstacles, but I don't think they're a roadblock. I think it's just like, all right, we got to figure this out as we go, because it's going to happen and I'm excited by it. So I don't mean to be super negative, more just like, all right, we got to figure all this out together.
Yeah. Yeah. Holly, Wendy, how are you currently handling it in Guardian and Early Check for counseling? What does that journey look like? And also, how do you see it evolving over time?
Yeah, so I'll start with this and say that I think there's a real opportunity. And I think this podcast and things like this help with that opportunity. So the first is that I think you have to design the test in a way that makes the consenting, and I'll use that word, in the education with the consenting, relatively simple to cognitively understand. And so what I mean by that is, if you focus on, again, the principles that I put forward that our families asked for: news you can use, early onset conditions, highly penetrant. I agree with Holly, ambiguity is the enemy of this in terms of things. If you make it a relatively simple decision, I think, for instance, the people who decide not to do our study are people who don't want to be part of research. It's a complicated time for them and they're just not research oriented, and that's perfectly fine. It's not that they are not interested in information that they think might be helpful to them and their family. And so I think that decision, as a relatively straightforward decision, doesn't require a lot of pre-test counseling. It requires some education, and I'll get back to, again, the opportunity, but I think that's not a complicated thing. And so we don't have genetic counselors. We go, just to explain the process of consenting and education for Guardian. The intense part is done at the bedside postpartum prior to discharge, where we have coordinators going by the bedside, face-to-face, in person, being able to talk to families, usually the mothers and the fathers when they're there, or any other family members at the bedside, about what this is. But we've introduced this in the third trimester in more of a passive way with written materials in the sort of delivery packet as they're getting ready for delivery. With that, the conversations can be enhanced with a genetic counselor who's always on site and able to fill in the gaps when questions come up. But they're individuals that are talking to families who are from the community, literally speak the language, understand the culture, are, really, I think, have their pulse on what our participants at each site are like, and they're different, and we have different coordinators at each of those sites for that reason. And I think that's been, again, when we look and survey people, participants, that is, I think that's resonated and has been very straightforward, and they don't have decision regret after making those decisions. What I do think is going to happen, I hope, is what I call the Angelina Jolie effect. And so what I mean by that, for those of you who can remember back to this, is, and I grew up with this before we even knew what BRCA1 and 2 were. The early days of hereditary breast and ovarian cancer, we went through very long counseling, education sessions, often multiple sessions to be able to educate and inform women before they made decisions about genetic testing for hereditary breast ovarian cancer. I myself have gotten criticisms from some of those patients early on about, for instance, why it took so long, especially right after diagnosis, because they were making decisions about clinical care, that it took so long to get their genetic testing. They then went back and said, well, I would have made different decisions about mastectomy and then radiation and reconstruction and all sorts of different things. Why don't you accelerate this whole process so I can make real-time decisions and do them, with full information in hand? And Angelina Jolie, in what I think of as a very bold move in terms of putting herself out there with a New York Times editorial, really increased the discussion in the public square about this and got people to think for themselves. What would I do if I were in her situation? If I, in the future, found out that I have breast cancer, if I have a sister with breast cancer, what will I do? And it allowed them to really go through those scenarios and talk them out in coffee shops and book clubs, waiting in the grocery store line, whatever it was, but it helped them to be able to think through it and to be able to be ready to make a decision if they found themselves in that situation. I actually think that's what's going to happen here in terms of this type of newborn screening. It'll be discussed enough around sort of in the waiting room office of the obstetrician, or, in the book clubs, or, at your son's soccer practice. And I think people will be able to decide for themselves. So it won't be such a cognitive burden at potentially an emotionally difficult time, or, one where they might feel a little bit tired, or however it is that it happens now. And I hope in a future state, as we have some experience and have that public discussion, we do get, number one, informed consent, and we can think about best ways of being able to support individuals as they're deciding.
Yeah, I think that's a great perspective. Holly, what do you think on that?
Yeah, I think it is a great perspective. It's a bit optimistic, and the data will show, right? We're gonna find out. I mean, I think there are so many challenges in public health and about people's trust in public health infrastructures, and we've seen a lot of pushback in even very traditional state newborn screening about the type of screening that's done and how samples are used, and so there is a bit of a challenge, I think, especially in this sort of day and age around newborn screening. But I'm going to go back to the concepts around sort of feasibility. And Kira, besides the pre-test counseling not being feasible, it's also, I don't think, a good use of our genetic counseling and clinical genetic resources. And I agree with Wendy that it is the responsibility of research teams now and in the future, maybe public health professionals, to develop materials that are understandable and acceptable to people. Our consent is entirely electronic. Even when we have in-person recruitment, the large majority of our individuals are not recruited in person. We do a range of different asynchronous, low-touch recruitment, and all of our consent is electronic, regardless of how they're recruited. The electronic consent we've evaluated for years, and our evaluation is very positive and similar to what Wendy has said. We don't have the decision outcomes for this phase of the study, but historically our decision regret has been almost none. And that includes people who've gotten false positive results. So people can, I think our studies are generating a lot of evidence that people can make good decisions about whether they want this sort of information for their babies in situations where research teams and maybe in the future public health providers do a very good job in their consenting and educational materials. It's a very high bar. It took us a year to develop and test our informed consent in our first phase of early check, and it took us a second year to develop and refine and test our consent approach for this new phase of early check using sequencing. So this is not an investigator sits in a room alone and, writes up a consent form and turns it in. That's definitely not the approach that we should be taking when we're doing large scale research, especially research around infants. But there are many models that have tested different ways to do appropriate asynchronous consent, and they work very well. People really like them. There are some access issues we have to deal with, but the public's access to Wi-Fi and built smartphones especially is extremely high. So we do work with people, and we have our professionals available to answer questions, but we get very few questions. People can email us, call us with questions. We get very few of them. So we do have good indication that the sort of old world of pretest counseling is not only not necessary, but it's actually not preferred for people who are enrolling in the study. After we've identified a baby, of course, it's a very different situation. We do need professionals who are trained and able to provide information, but similar to other situations, we also need materials that people can access on their own that are about early identification, and in many cases, asymptomatic newborns who were saying your child is very likely to have a significant phenotype, but the parents look at the baby and say, my baby is doing great. And that is really complicated and really challenging. And I think that actually is the place where we have the biggest gaps right now in terms of developing both educational models, but also counseling models to help families anticipate a likely but not sure outcome in a newborn.
Yeah, and maybe pulling on that thread a little further, is another gap how the healthcare system as a whole helps you to take those cases and pull through on them, because it seems to me that we may live in a system where we're more used to being reactive, where that child shows up with symptoms a year or 2 or 3 or 4 after you might have found them through a screening program, and now they're entering the system at a really different time, which is with a uncertain risk factor. Maybe you all can talk a little bit about that aspect of how we get these to the point you made at the top of the show, which is going all the way through to getting a good clinical outcome, not just finding the screening result and moving on from there.
So I think it's a great point, and I'll put it out there in terms of some of the challenges we're facing, but some of the opportunities. So I'll put out the example of Wilson's disease, which is a copper overload condition, which we included within our panel. It's a condition which is very readily preventable by simple zinc supplementation to be able to outcompete the copper and a low copper diet. It's something, though, that you don't have copper overload as a newborn. It takes time in terms of acquiring that. And so again, it's a recessive condition, and one of the challenges we've had is trying to think about equity and how do we make sure we're not leaving particular communities behind, where knowing the variants that are pathogenic in that population might not already be known as well as for white or European populations. And so we set out in Guardian as an example in terms of, given that we included Wilson's disease alleles where we had one allele that was pathogenic or likely pathogenic and the other variant, we were willing to tolerate a variant of uncertain significance, but that we're leaning likely pathogenic. And for us, that was the balance in terms of trying to be inclusive, but not trying to have a lot of false positives going forward. We built in actually assays that would also be able to look at the newborn screening blood spot and do a secondary test in addition. So again, trying to minimize that ambiguity, uncertainty, and anxiety that goes in. But we've realized that other test, that orthogonal test, is not perfect. And so we still have a few babies, thankfully not many, but that we're sitting in this limbo, and to Holly's point, in terms of anxiety and not knowing definitively one way or the other. I can tell that that's going to be something for anyone that screens for Wilson's disease is now going to be a thing that we have to think of. Does that mean you don't screen for Wilson's? I think not, given the opportunity with such a easily adopted, inexpensive, effective way of prevention. But on the other hand, you don't want to wait physiologically for a newborn to show or a child to show evidence of copper overload to be able to make a definitive decision. And for the research community to now start testing functionally all sorts of variants of uncertain significance, we don't have the machines available to do that. Like literally, I don't have the funding to give the researchers to do that. So it's an interesting space we're living in terms of that thing. I think we had to do the experiment to uncover and really see what the severity or what the magnitude of that issue was. But I can tell that this won't be the first of the lots of those conditions like that. And as Holly was saying, but just to be really explicit on this, when you're doing population-based screening of this, what you thought you knew about those conditions, you have to unlearn. And so I can give you many examples, but we're unlearning what we thought were the rules in terms of these things. It's an important to do, but you just have to be willing to learn as you're going forward with this.
I think that's an interesting thread to maybe finish off on. If there are examples of from each of you, either one thing you've learned working in this or something that you'd have to unlearn. And I think, this point about what you learn from ascertained populations being very different from what you see in broad population screening is a really interesting one. So I'd love for you all to cover that one, just to give people a sense of what dogmas you're needing to rewrite as a result of running some of these in a new way.
Well, I'll just give you one example since we now have been gathering the data to do this. So we included within Guardian long QT syndrome because it's something that is a cause even of sudden infant death syndrome and sudden cardiac death. And there are things that you can do about it there's a lot of good evidence base for this based on the long QT registry. But I have to admit, and I know the folks who have generated and analyzed these data, it was based on individuals who are clinically ascertained, who came to clinical attention, at least for one member of the family. And these are dominantly inherited conditions for the most part. We've identified and realized now that this condition is more frequent from a population-based ascertainment than we appreciated previously. And these are true positives. That is that when we go and then do an EKG on these individuals, they really do have prolonged QTs, but they're being ascertained as newborns who thankfully haven't died and they haven't syncopized, so they haven't been symptomatic, and what their risk profile is like and how it might change over their life course. So in other words, an EKG on a newborn may be different than an EKG on someone during puberty or other life stages. And we just don't have their time, their life to be able to show physiologically how it's manifesting. And so while we have very good evidence-based guidelines in terms of treating these individuals, I think we're going to have to write different evidence-based guidelines for those ascertained as newborns than we did for what's come out for those largely ascertained through either family history or through being symptomatic. So it's important to do, but I just leave open, we've got a lot of work to do to be able to get there. And in the meantime, before we have all of the evidence-based guidelines, we've got to use common sense. And I do think it's important to be able to, use common sense and go forward and to be able to realize that I think we've got something to offer, but it may not be perfect initially.
Yeah, absolutely. Holly, how about you?
Yeah, it's far from perfect initially. And that's part of why we're doing this research, right? I mean, there's, I think one of the, fascinating things about differences between our programs is that while I would say that kind of at a philosophical level, our thinking about conditions that should be included on our panels are quite similar to Guardian. There is very little overlap between the conditions that actually are on our panels. And so it's the whole decision making about what goes in is really impacted by that evidence, or in many cases that lack of evidence currently about what kind of impact we'll see on the population level. So I'll give a couple of examples. So one of them is there are many conditions that are on our panel and across other panels that have a dominant phenotype and a recessive phenotype. And you get a baby who has one variant, and it's very difficult to know how to manage that with the family in terms of the counseling and the follow-up. And those are quite common. Another thing that has been a challenge with us is that we have sometimes we have disagreement with other kinds of testing people have done. And we've seen that with people who've had prenatal panels, which Kira, you were talking about. So we've had people who say, actually, this can't be true because I've already had a prenatal panel, and that's an interesting, complicated thing to work through. But I think more challenging in the context that we're working in is we've already had a situation where we've had a discrepancy between the newborn screening result and a result that we generated from our study. And it's a very explainable discrepancy. This is a hearing loss condition in that the hearing loss is not always noticed at birth. This hearing loss can actually happen later over the child's life before the child turns 2. And we had a situation where we identified a child with deafness, and initially the newborn screening done by the state did not pick up any hearing loss. And over time, over the past couple of weeks, that child has had a second hearing screen and does indeed have hearing loss, as we anticipate based on our screening results. So when you put those kinds of things in front of families, we have to just be extremely careful. And I think that's why these close collaborations that many studies have with the state public health programs are really important, because we need to develop messaging that is not going to harm the existing newborn screening program, and also give families some kind of model to understand why we might reasonably see these discrepancies. And it's not that there's something wrong with the state newborn screening program. It's that we're doing different kinds of tests using different kinds of assays, and we're going to find different kinds of results in these cases. So I think there's just so much nuance and complexity that we're dealing with that really requires data from studies like ours to be able to inform the field moving forward how to do this properly.
Wonderful. Kira, you get the last word on what you learned or unlearned through some of your work here.
Last word, no pressure. So I think with a lot of this, we've been talking about, okay, having those results, processing them, making a plan. But I think there's also spanning out a little bit more. Okay, we have this genomic information, whether that ends up being an exome, genome, that Dr. Chung was kind of saying, not sure where we'll land with that. But there will be other information in there that will be valuable for people to have long term. So I'm thinking about, people may or may not want to know if they're at if they're at an increased chance to develop early onset Alzheimer's, right? So I think that's one that I think about in terms of, some people don't want to know that. Some people do want to know that. There's definitely a lot of thought that should go into learning information like that. Or say Huntington's disease, that we would, see in the family, but, not everybody has access to family history and different things. So what does that look like long-term for the adult onset conditions or cancer predispositions? Because if we're doing it, exome or genome, we're going to have this information. And there's this concept that Dr. Short, I know you've talked about, in terms of like a genomic passport. And is this information going to follow that person? How is it going to follow that person? They're not probably going to live at the same address for their entire life. They're probably not going to live in the same state their entire life. So what is our healthcare system? What is our setup, especially in the United States, where things are so fragmented, where we don't have universal healthcare like Canada and the UK, where I imagine, from talking to a lot of people on my show and everything, that we may see this implemented in other countries that have universal healthcare, and say, all right, what can we learn from this? Just like we're learning from these 2 studies today, and that you guys are learning from each other. What can we learn from that? Because there's not a central database. There's not, in the United States, like we don't have, oh, well, this can just follow you. People change insurance companies multiple times throughout their life. So how is that information going to be, can we even really, I guess, not how, but can we, have them be accessing that? Because otherwise, all right, so that person's going to pay for another genome in their life. Like, is that really necessary if we've already sequenced that information? And then you get into, all right, well, how good was that sequencing, right? Like, what is the depth and the coverage of that sequencing for those that are, total genetic nerds out there? So there's a lot of things, but I think about that long term. Like, we have this valuable information. Do we just say to the parents, hey, here's a USB drive, here it is, if you want to just, put it in a vault somewhere and have your kid find this, or put it in the cloud and have a QR code, the security of that. So I don't know, a lot of things that I think about, as I like thinking about the long term and the future kind of as we close out.
I agree. Well, thanks everyone. Like all good panels, lots of questions answered, but also lots of new questions to ponder on as we take it away. So thank you all. Appreciate all your great work in this space and the time today.